But it is my pleasure to introduce Dr. Guadagnoli, who in 2012 ran the Highlands Wellmont Health Network in Bristol, Tennessee, was as the CEO and medical director, and then came here in 2016. And he's been appointed the UMass Medical School Associate Dean for Medical Education at Cape Cod Healthcare. He's also an assistant professor of obstetrics and gynecology for the medical school and the liaison and site leader for Cape Cod Healthcare. He is an OB/GYN by training, originally from Rhode Island with undergraduate and medical degrees from George Washington University. But his real passion is what we're here about today, to talk about today. And he is, in the short time that I've known him and got to know people that have had an opportunity to work with him, incredibly respected in the field. And he's a man of great compassion. And we are very beneficial. We benefit as a community by having not just a member of the medical staff, but the chief of the medical staff lead this discussion in our community. So without further ado, I would like to bring to the stage Dr. Don Guadagnoli.
Thanks. Thank you, Paul. Paul, thank you very much. First, thank you all. I really appreciate everybody being here. And I'm hoping that I can convince you, that we can convince you. And let me take a minute to introduce Tina Soares. Go ahead and stand up. Tina is my partner in crime here. That we can convince you of how important what we're going to be talking about is, and of your role in helping to deal with an issue that exists within our community. We can't do it alone. We recognized this a while ago. The first question I have, though, is of the people who are here, how many were here for the Quality of Life Summit that we had in 2015? So we got a fair number of people from that, but we have a fair number of people who aren't from that too, which I'm really grateful to see. It's always, when you throw something like this, you always wonder how many people are going to show up, and then when God decides he's going to throw a ringer in there the night before, it makes it a little bit more difficult. But I'm grateful that all of you are here to hear about this important topic. We started out the last Quality of Life Summit really with a story, and I'm going to encapsulate that story today, but really with a story that was written in the Wall Street Journal that kind of highlighted the problem, because right now everybody's saying, okay, so what's the problem? He hasn't told us that yet. This story was written by Ken Murray, who's an orthopedic surgeon, and it was written about a mentor of his who was also an orthopedic surgeon named Charlie. Charlie was given a diagnosis. He was in his mid-60s and received a diagnosis of pancreatic cancer. When he received this diagnosis, he had a fair degree of clarity as to what was going to be coming next. And so Charlie went ahead with this diagnosis, which, by the way, for the non-clinical people in the room, pancreatic cancer is not a good cancer to have. The 5-year survival rate for pancreatic cancer, even today, is relatively low. It's not something that has good outcomes to it. Charlie closed his office. He never set foot in a hospital again. He went on to spend his time with family and friends. He focused on what was important to him. He made sure that his family understood what was important to him and what he would and wouldn't want. And he died maybe a little quicker, maybe a little longer than if he had had anything done. But when he died, he'd had no chemotherapy, no radiation therapy, no surgical therapy, despite the fact that the surgeon who gave him the diagnosis was somebody who did surgery for pancreatic cancer, somebody who was well-versed in the field and thought he could give Charlie some hope. But Charlie knew that this wasn't going to end well, and that what was important for he and his family was to really go through this journey in a way that was comfortable for him and brought closure to his family. And when we told the story at the beginning of the last summit, what we pointed out was it's not fair. it's not fair that the only people who understand healthcare well enough to be able to choose a reasonable exit strategy, if you will, are the physicians and nurses who are actively involved in healthcare. And we need to make sure that a broader audience understands this. One of the things Paul said, I'm an OBGYN by training. I left practice in 1998, but quite honestly, in OBGYN, end-of-life care is not something that really is something we deal with. Almost by definition, if you're an OBGYN and you're dealing with end-of-life care, you're having a very, very bad day. When I got to Cape Cod Healthcare, it brought me back into the clinical environment where I could spend time with our physicians and nurses. And what struck me was how often I was running into our frontline caregivers who were in tears or next to tears because they felt as though they were doing something to somebody rather than for somebody. And that's not what we want to be doing. The problem is patients' expectations are pretty remarkable at this point. Healthcare has changed and advanced remarkably over the years, and our patients' expectations, and especially their families' expectations, are sometimes out of line with reality. If we look back, gee, it looks like a significant portion of the room may remember Marcus Welby. The rest of the room can Google Marcus Welby. Marcus Welby had really just gone off the air around the time I started medical school. So 4 decades ago, when I started my journey in medicine, Marcus Welby was kind of what everybody saw the physician to be, the quintessential family practitioner who cared for people in the community, who maybe even did house visits, who took care of you when you went into the hospital, who knew you for 20 or 30 years, and who, when end-of-life events were approaching, could help shepherd the family through that. Fast forward 40 years, things have changed fairly significantly. We don't have, we have inpatient and outpatient physicians. We don't have somebody really who's known the patient for that long, typically involved, which means we've got a very short time to have trust with the family. We've also changed very significantly what happens in medicine. When Marcus Welby was popular, when you came into our emergency room having a heart attack, we gave you an aspirin, we controlled your pain, and we told you sometime over the next 3 or 4 weeks we were going to figure out how much of a cardiac invalid you were going to be if you survived. Stents were experimental at that point. Now when you come into our emergency room, we monitor the amount of time from the time we figure out that it's a cardiac event to the time we get you into our cath lab for our interventional cardiologist to reopen that blood vessel so that the heart muscle doesn't die and so that you're not a cardiac invalid. When Marcus Welby was on, cancer was a death sentence, almost universally, and often a fairly brutal death sentence, although often a fairly quick death sentence. Today, cancer, many cancers at least, are chronic illnesses. Some of them are actually curable. And so what we're seeing is that people who might have died earlier are living longer and longer and longer. I'm an example of that, partially because I quit smoking and I lost weight when I needed to do that, partially because antihypertensives and anti-cholesterol drugs have been around for the better part of my life and I've been taking them. But I've survived and now outlived most of the males on my mother's side of the family. What does that mean? What that means, part of what that means is I don't know what's ahead. I don't know if the males on my mother's side of the family would in modern times live for another 30 years. I don't know whether they develop Alzheimer's disease. I don't know a whole lot. But what I do know is I'm pretty healthy right now and moving forward. And what we knew was we needed to begin to move forward with getting this out to the community. So as we looked at it, and really 2016 was our time to look at it, out of the last healthcare summit, we built a large task force, and there are a lot of task force members here today, and I'm very grateful to the task force members because they've helped guide where we've gone. we initially looked at the forms. There's a lot of planning documents that are available that have to do with end-of-life issues, most of which we dismissed. I'll tell you, when we went into it, my thought was we were going to focus on what are called MOLST forms and/or care measures only forms. MOLST forms are medical orders for life-sustaining treatment. They're the forms that say, I do or don't want to be resuscitated, I do or don't want to be intubated, I do or don't want to have hemodialysis, I do or don't want to have a G-tube. I initially thought, and we initially thought, that's where we were going to focus. We rapidly figured out that MOLST forms were not the place to focus, because most people in this room, myself included, probably couldn't fill out a MOLST form. It kind of depends. It depends on what led me to the illness. It depends on where I am in the illness. What we ended up focusing on was the healthcare proxy form. Because no matter how old you are, no matter what your state of health is, the healthcare proxy form identifies a healthcare agent who can talk on your behalf if you can't talk for yourself. The choosing of the healthcare agent means you have to have thought through and had a conversation with your agent and the family and your family about this so that that agent can make a reasonable decision. So when we decided to focus on that, we also decided that really we needed to do this as a community and across the spectrum. The reality is, if you wait until just folks are in their 80s and 90s to have these conversations, there are a couple of things that happen. The first is everybody tries to avoid the conversation. The second is, what you do is you preclude people who are younger than that from having their families know what their wishes are. And so what we wanted to do was try and drive it out into the community. And this is the reason all of you are here today, I hope, and across all spectrums of jobs, is because you represent a whole array of folks within the community. One of the things that we decided was we need to drive it down to the younger ages. The time to have this conversation, a good time to have this conversation, is when you're sending your child off to college. Your child turns 18 and goes off to college. The college says, give me the check. You say, give me the grades. They say, forget it, they're an adult. We say the same thing in healthcare. You can no longer automatically speak for your child once they turn 18. What a benign time to have a conversation. When your kids are going off to college, you and your spouse are healthy, you're relatively young, and you're introducing into your family the fact that this is a conversation, and by the way, you can educate them, and it's a conversation that needs to recur. It needs to recur because at some point, you're going to get married in all likelihood. When you get married, you're going to have to think about, is my spouse really the person who can make this decision, or are they going to find it too difficult to make? Do I want one of my siblings to be that? So you can introduce in the concept that this needs to be a recurrent conversation too. It's not just a one and done type of thing. And it introduces into the family the concept that these are normal conversations that we have, so that when mom and dad are in their 80s and 90s, they've probably already had these conversations as a family several times. We need your help with that though. We have not been successful getting into the community colleges that are here locally. We haven't been successful getting into the high schools, just not high on the agenda. I understand that, but it's one of the strategies, and I think it's a very reasonable strategy for us to be pursuing. As we assessed the area, what we realized was, first of all, there was no standardized approach. The approach historically has been, well, the primary care physician should have that conversation. For a number of reasons, not the least of which is most primary care appointments are only 10 or 15 minutes. That's probably okay sometimes, but it's not really a successful strategy across a community. It also isn't necessary. I don't need a doctor to tell me that what's important to me is hopefully being able to see my grandchild graduate from high school. That's something that anybody can guide that conversation. So we sought to train people to help guide those conversations. We also knew that most people did not have any documentation in our electronic medical record. And we've worked on making that, making sure that that happens too. The terminology is extremely complicated. There's a lot of confusion around what a healthcare proxy is. The form is the proxy. We tend not to focus on the form, because if you focus on the form, you'll get the form. And the agent will be the next door neighbor who has no idea that they're written on there. We focus on the conversation and then say, and by the way, we need the proxy form to be filled out. And by the way, if it's in your safe deposit box at 3 o'clock on Sunday morning when you're in the intensive care unit, we have no access to it. It needs to be in our electronic record, and we've developed strategies and an ability to easily get it into our record. Work is in silos, and that's partially a byproduct of where we've come technologically in medicine. Marcus Welby can't exist anymore. We can do too much good for too many people to have it in the hands of a generalist who isn't able to guide that. We have to have endocrinologists and neurologists and inpatient hospitalists and et cetera, et cetera, et cetera, because these are the people who are the experts in their field to help guide the care. We have to have generalists too. The primary care docs are excellent at quarterbacking all this, but they really can't be the be-all and end-all to this. And one of the things that we're finding, though, is as more and more physicians get involved, everybody has a tendency to believe that the conversation is happening somewhere else, which means the conversation isn't happening at all. So over the time frame from October 15th on, we spent 2016 in planning. We developed the toolkits, and the toolkits are on your table. They're these booklets that we developed with our partnerships with Honoring Choices. We've made some important partnerships with very significant groups across the state. I initially said, well, the first thing we did as Cape Cod Healthcare was take Tina Soares, who was one of our hospice and palliative care nurses with a passion for this, and move her over into position of, okay, Tina, it's now your responsibility to get 250,000 healthcare proxy forms into our electronic record within 5 years. But we initially sent her out to La Crosse, Wisconsin, because Gunderson Health System out there had gone through much of this journey. And she came back and she said, first of all, they want to charge us an ungodly amount of money to do this, and second of all, we really don't need to do it that way. We've got enough good resources here in Massachusetts, and we capitalized on those resources. We've partnered with the Conversation Project, and you'll find some of the booklets in there to get conversations started. Our toolkit is partnered with Honoring Choices, which focuses mostly on the healthcare proxy form. You'll notice that our toolkit has two parts to it. There's a healthcare proxy form and guidance in the front, and then there's living will and guidance in the back. One of the things for folks to remember is in the Commonwealth of Massachusetts, the living will is not a legal document that has any binding capability, which is why it's so important. It's good for guidance, but why it's so important to have that agent identified and knowledgeable. Other groups that we partnered with the Institute for Healthcare Improvement to help guide us and make things a little bit more formal and a little more evidence-based, and the Massachusetts Coalition for Serious Illness Care. The Massachusetts Coalition for Serious Illness Care is a partnership between Blue Cross Blue Shield of Massachusetts, and we have Mr. Dreyfus here from Blue Cross today, and Ariadne Labs, which is a leading innovator in research in this area, run by Atul Gawande. That partnership to form the Mass Coalition for Serious Illness Care is something we've been involved with from the beginning because we need to learn. We need to know how we can get this across as broadly within our community as we can. Because I don't want to see my physicians and my nurses in tears caring for somebody because they think that they wouldn't want that themselves. One of the things we know from the research that was done by these groups is that about 80% of the people say that if an action you're going to take is going to impact the quality of my life, please don't do it. We also know about 14% of the people say pull out all the stops. What we don't know is who's in which category. And when Tina and I go around and talk to some of the retired citizens groups and things like that, we tell them, you know, our docs and nurses will take care of whatever it is you want us to do. But you have to have clarity about it, or if you can't speak for yourself, your family has to have clarity about it, because if you don't, then we're not going to know. And we don't know whether you're in the 80% category or the 14% category. As I've said, one of the things that we want to do is get out of just waiting until end of life to discuss these, but really have planning occur across the spectrum. We've been successful. I hate to use healthcare proxies because, as I said, if you ask for a proxy, you'll get a proxy filled out. But we've controlled where they go, and we've been relatively successful. We've doubled the number that are coming into our electronic record on an annual basis, but as you can see, we've plateaued also, which was part of the reason that Tina and I decided, gee, it's time to bring people back together again. It's time for them to understand what we've developed over the last 3 or 4 years that can be used by the wealth management community, the legal services community, the elder services community, any of the medical community, any of the people represented across the spectrum here to get the message across. Why is it important here? Because Barnstable County is kind of unique. We have almost double the population of people over 65 of either the state or the country. We have a population that needs to have thought this through. And it's increasing, by the way. When we started this, when we first did this in 2015, the number wasn't 30.6%, it was 27.8%. This is the distribution across the Cape. The other thing, as I've said, is we need to deal with the population and the recognition of the population as to where their shortfalls are, where their stressors are. It's pretty easy if you have cancer, congestive heart failure. You know you've got a serious illness and you know that you have something that will potentially shorten your life. If you are hospitalized with congestive heart failure, there is a 50% chance that within 5 years you're going to die. If you get re-hospitalized, there's an 85% chance that within the next 5 years you're going to die. Now, you still have choices you can make there. Mom had congestive heart failure. Mom preferred corned beef and cabbage and ham, and Mom was happy with that. Okay. Unfortunately, that wasn't optimal care for her congestive heart failure, but it was her choice, and that's fine. The problem is, as we've turned many of these diseases into chronic illnesses or things that we've cured, what we've uncovered and begun to uncover more and more are dementia illnesses, Alzheimer's disease, people who are getting to functional limitations as they age because just the chassis is getting older and it doesn't function as well as it used to. I know mine doesn't. And frailty issues. And these also are prognosticators for end of life, and they're things that people need to be aware of. Now, when we talk to senior groups, the senior groups are aware of it. What we encourage them to do is make sure they're talking to their children. The seniors know that they're not functioning at the level they were. They've seen their friends. They understand that at 85, pneumonia may be an event that begins to topple the house of cards. A lot of times their family doesn't, though. And their family is presenting and saying, what are you going to do to fix this? When in fact the patient understands. I mean, I understand. If I develop pneumonia today, I am not going to bounce the way I would have 20 years ago. The other thing that we point out to folks is if you don't tell your kids, they see what they expect to see. My kids see that I go up and down the stairs and I have no problems doing it. What they don't see is I hold a rail now because I'm not an idiot and I know a fall is not going to do me any good at my age. And what we've seen, as I said, is an increase in Alzheimer's disease and a prediction that Alzheimer's disease will actually increase by about 25% over the next decade. So it really is a significant illness for us to deal with. And there are strategies, and that's the other thing that we can talk about, and we're going to talk about this afternoon, is some of the strategies that we've built into healthcare locally to help deal with this. So our plan is to improve the medical record process, and we've made some great advances on that, to provide ongoing training for our clinicians and employees, but also for the broader community. Because as I said, it doesn't have to be clinicians only who are raising this and who are having this conversation with people in the community to spur the conversations in the family. We're providing standardized resources and materials, and that's one of the reasons we developed this. And we've got folks from the foundation here, and I want to thank our foundation. We've had some foundation money to help print these so that we can give this out to all of our partners across the community, so there is a consistent booklet that's being given. But the bigger reason we wanted the consistent booklet being given is because if somebody walks into their primary care office with this, it should send the message that we don't just give these to folks. You can't get these unless we understand that you understand that a conversation is what's important, and a healthcare agent who's knowledgeable is what's important, not just the form. So we're giving them to folks who actually are going to, whether it's, and by the way, it's not just doctors' offices, it's legal offices, it's wealth management community, we will give them to anybody as long as there's an assurance that the conversation will be promoted along with it. We're implementing workshops, and we've got a number of ambassadors here who've worked with us. As a matter of fact, would the ambassadors stand up for a minute? Ambassadors who've worked with us as part of our task force to help. Thank you. And I truly, I don't make a lot of the meetings. I apologize for that, but I truly appreciate all the great work that you guys have done with Tina and all the guidance that you've given us. It does get back to me, and I do understand the guidance. So, basically, the model is just conceptually. First, we need to get people to explore. They need to think through, and talk through what's important to them. Then we need to get them actually getting it in writing, and then we need them to get it to us. And we've got processes in place for that to happen. So far, we've built a platform to help bring our key partners together. As I said, we've had the strategies, and we've trained the ambassadors.